Good afternoon, everybody. Thank you for joining the ASTP HTI-2 Proposed Rule, Patient Engagement, Information Sharing, Public Health Interoperability Proposed Rule session. My name is Josh Shapiro with Capital Consulting, and I'll be assisting with the logistical support for today's session. If you need technical assistance, please click on the chat icon at the bottom of your screen. Type your issue into the chat, and one of our techs will respond to you. Finally, please be aware that today's session is being recorded. Closed captioning is available by clicking the CC icon at the bottom of your screen. And now I will go ahead and turn things over to Alex Baker at ASTP to get things started. Alex, all yours.
Great. Thanks so much, Josh. And thanks to everyone for joining today. My name is Alex Baker, and I am a deputy director in one of the divisions in ASTP's Office of Policy. And I am joined by Johnny Bender and Scott Bohan in ASTP's ONC's technology office and our tools and testing branch, who are going to be covering some of the other details about these proposals in just a moment. Next slide. So first, a couple of overall disclaimers here. The materials contained in this presentation are based on the proposals in our HTI-2 proposed rule, and while we have sought to ensure the accuracy of this restatement of those proposals, it is important to note that this presentation is not a legal document, and the public should refer to the proposed rule text to see the official proposals. We also want to note that ONC must protect the rulemaking process and comply with the Administrative Procedure Act. And during the rulemaking process, ONC can only present the information that is in the proposed rule as it is contained in the proposed rule, and cannot interpret that information or clarify or provide further guidance. Additionally, ONC cannot address any comments made by anyone attending the presentation or consider any such comments in the rulemaking process unless those comments are also submitted through the formal comment submission process as specified in the Federal Register. And finally, this communication is produced and disseminated at U.S. taxpayer expense. Next slide. So first want to give a very brief overview of HTI-2 proposed rule, just to orient folks, and then we will dive into the specific topic for today, which are a series of proposals for certification criteria in the ONC Health IT Certification Program that we are grouping under the title Patient, Provider, and Payer APIs. Next slide. So the HTI-2 proposed rule is a extensive new proposed rule with a variety of different proposals touching a large number of areas. Some of the major goals for HTI-2 are continuing implementation of the 21st Century Cures Act, for instance, through additional proposals and revisions to existing policy around APIs that allow electronic health information to be accessed, exchanged, and used without special effort. The rule also touches on information blocking policy established under the 21st Century Cures Act, focusing on new and revised policies around reasonable and necessary activities that do not constitute information blocking. So the exceptions to information blocking that ONC establishes. And then finally, establishing the qualifications necessary for an entity to receive and maintain designation as a qualified health information network capable of trusted exchange pursuant to TEFCA, which was another key element of the 21st Century Cures Act that we are continuing to drive forward in this new proposed rule. The proposed rule also touches on a number of important executive orders and furthers those executive orders through its proposals from the Biden-Harris administration. So executive orders such as the executive order to around ensuring a data-driven response to COVID-19 and future high-consequence public health threats, and the executive order around advancing racial equity and support for underserved communities. And then finally, the proposed rule continues to advance a number of ASTP ONC's broader initiatives and goals, such as leveraging our authority under the HITECH Act, generally advancing interoperability and providing a variety of enhancements and improvements to the ONC Health IT certification program. Next slide. So just a quick overview of some of our key goals for HTI-2 in these proposals. These include advancing health IT infrastructure nationwide, minimizing data silos so health IT users can access information from various settings, emphasizing technology solutions that are easier to adopt, particularly in settings with limited resources, enhancing interoperability across healthcare and public health, advancing equity, supporting patients' access to lawful reproductive health care, and strengthening support for actors honoring patients' individual privacy preferences. Next slide. And one more. Okay, so with all of those kind of big picture goals for HTI-2 in mind, we want to dive in on one set of proposals that we are pretty excited about as a sort of new topic area for the Health IT certification program, and one that is very tied to other work across the department to advance interoperability. And so these are, again, what we've been titling the patient, provider, and payer API capabilities, which are a series of proposals for certification criteria. These are numbered G30 through G36 in the CFR in the our section with certification criteria. And these criteria are focused on supporting the availability of health IT that can help enable payers and healthcare providers to meet a series of requirements that have really been spearheaded by CMS in a series of rulemakings over the past several years. And we see these criteria as enabling implementers to ensure that the APIs developed to meet these CMS regulations can adhere to relevant interoperability standards and support other features important to effective information sharing. In general, these are certification criteria that are focused on enabling exchange of information that promote a more effective marketplace, increase competition, reduce administrative burden, and provide benefits to patients, such as increased consumer choice. Important to note before we go into some more of the details that around the relationship of these proposals to other policy activities across the department, that the certification of health IT modules by health IT developers to these criteria are voluntary, as they are across the health IT certification program. And so the proposals in this proposed rule do not establish requirements for health IT beyond those health IT modules submitted for certification for these criteria under the program. And the availability of these certification criteria, if finalized, would not require any individual or entity to use the certified health IT, including those payers subject to the CMS requirements. So an important distinction about what these proposals do, that they're supporting the availability of certified health IT, but there are not further requirements for use that are contained within these proposals. Next slide. So just want to quickly remind folks what the final policies in the CMS interoperability rulemaking final rules that we have based these criteria on, and that these criteria are intended to support. So back in 2020, CMS released the interoperability and patient access final rule, and that included two final policies that we want to focus on here, which were the The patient access API requiring a series of impacted payers to establish and maintain APIs that can allow patients to use a third-party app to access both administrative and clinical data that may be held by a payer that manages a health plan which they are part of. So a very important initiative by CMS to increase access by patients to their information that is held by payers. And then the other API we want to focus on from that rule is the provider directory API, which required that same set of impacted payers to establish an API that would make available provider directory information about providers that are in their networks for their coverage. Then more recently, just at the beginning of this year, CMS released the interoperability and prior authorization final rule. So this is a wide-ranging rulemaking, and folks can refer to the CMS rule for all of the details. This included some additions and revisions to the patient access API for one, but 3 of the API policies that were finalized in that rule that are important here are the provider access API, which required that same set of impacted payers to now make administrative and clinical data available to healthcare providers to help them better manage patient care using that data that payers have that they can use for quality improvement and improving the value of care. The payer-to-payer API, which CMS finalized in this rule, again, can refer to CMS for some more of the details. A version of this had been originally finalized in the interoperability and patient access final rule, but the final requirements are in the interoperability and prior authorization final rule from earlier this year. And this requires payers to establish APIs that allow for exchange of important information between payers. So this is really focused on the case where a patient may change coverage and payers may have important information about that beneficiary that needs to go to the next payer who will now be covering that individual. And so this API ensures a mechanism for payers to exchange that information as for care coordination purposes as individuals switch plans. And then finally, very important policy that CMS finalized in that rule was the prior authorization API. And so this is an additional set of requirements on that set of impacted payers, which requires them to stand up APIs to facilitate electronic prior authorization processes. So CMS has focused on what we frequently hear is a very burdensome and manual process, and propose these APIs that would allow for completing both providers being able to find out about coverage requirements for a service or item, and then understand what information needs to be submitted for a prior authorization, assembling that information as part of the provider's workflow, and then actually doing the submission of that prior authorization, all according to a standardized process and standards developed by the industry. So that is the final API there that CMS finalized in the interoperability and prior authorization final rule. We'll also note that in that final rule, CMS finalized a measure in the Promoting Interoperability program focused on electronic prior authorization. So in addition to finalizing requirements that payers need to create these APIs to facilitate prior authorization, CMS has finalized a measure that would engage providers in doing electronic submission of prior authorization requests to those payers that have stood up these APIs. So an important final policy by CMS to address both sides of that equation, and that these are all final policies that you'll see as we go through our proposals in detail. We are seeking to support through the Health IT certification program. So want to note that as CMS has finalized these policies, as I've noted a little bit, they have focused on standards developed by industry that can be used to structure these APIs and ensure that they are being implemented in a standardized way that supports interoperability. CMS required impacted payers to use a series of standards and implementation guides, which ONC has already adopted as part of our program, as well as the US CDI standard that ONC also has adopted and manages for clinical data. So some existing cross-references between CMS's final requirements and what is finalized for use in certified health IT in the certification program. We'll also note that in the interoperability and prior authorization final rule in January 2024, CMS recommended an additional set of implementation guides that have been purpose-built by industry for these different use cases in order to support effective implementation of the required APIs, and those recommended implementation guides play a role in our proposals for HTI-2. So next slide. So for these proposed certification criteria in HTI-2, we are referencing both the certain standards that we've already adopted, as well as new implementation specifications that we have not yet adopted, but are proposing to adopt on behalf of the Secretary in this rule. And these standards and implementation specifications align with both the required and recommended specifications identified in CMS finalized policies for payer API requirements. So important to note that we have been working closely with CMS to seek to align the technical underpinning for these criteria with CMS's final policies for the payer APIs. And so with respect to those recommended IGs that I mentioned for the CMS rule in the HTI-2 certification criteria proposals, we are proposing to adopt current versions of those IGs in regulation and then reference those as part of the certification criteria in G30 through G36. These are the specific recommended specifications that we're now proposing to adopt for the certification criteria are all based on the HL7 FHIR standard, and many of these were developed by the HL7 Da Vinci project, which is a large initiative that has been especially focused on some of these use cases around reducing administrative burden in healthcare. Important to note that as ONC is adopting these standards in regulation, we would then review them for being part of our standards version advancement process. So these are a number of standards which we understand will be revised and improved on an ongoing basis going forward, and want to remind folks that our standards version advancement process would enable voluntary use of updated versions of these standards in the program as they become available if ONC approves those under the SVAP process. So an important way that we would focus on managing the evolution of these standards going forward. And then the last piece that I want to note as sort of an overall comment on the structure of these certification criteria is that these certification criteria include a number of references to the modular API capabilities that ONC is proposing in HTI-2. This is an important new approach that we've proposed in this rule that seeks to organize in a more streamlined way the requirements for the APIs that we're proposing here. And so as folks will see as they look through the rule, we have parsed out certain common capabilities for API implementation, such as capabilities for registration, capabilities for authentication and authorization, workflow triggers for decision support interventions, and subscriptions are just some of the examples of different pieces of functionality that apply to more than one of the API proposals that we have in this rule, and as well as some of the previous policies that we've finalized. And you will see throughout these proposals references to those modular capabilities that are included in a different section of 173.15. And each of the different API proposals points back to those so that we can have a more flexible approach to how we build the technical requirements for these API proposals. So that is covers the main overview material we wanted to go through. And with that, I am going to turn it to Johnny Bender to go into details about some of the individual G30 through G36 proposals. Next slide.
Fantastic, thanks. And I'm going to hand it over to Scott Bohan to get us started with the first few, and then I'll take over for the last few. Scott.
All right, thanks, Johnny. Okay, so here is a summary of the G30 criterion proposal. So as some background, we propose to adopt a patient access API certification criterion in G30. And this criterion would specify requirements for health IT modules that can enable patients to access their health and administrative information by using a health application of their choice. The proposed G30 criterion would reference many specifications, including Karen Blue Button IG, the Da Vinci PDEX IG, Da Vinci US Drug Formulary IG, and the US Core IG. And this criterion would broaden electronic access for patients beyond clinical information contained within health IT to include coverage and payer information. And this additional information could help patients with their decision-making. And this proposal also aligns with CMS requirements for payers to establish patient access APIs originally finalized in the CMS interoperability and patient access final rule. Next slide, please. Okay, so now providing an overview of the technical requirements of the proposed G30 criterion. So first, with application registration, we propose to require support for 2 registration pathways for a health IT module certified to the G30 criterion, a functional registration pathway and a dynamic registration pathway. The dynamic registration pathway would support applications that can support automated scalable registration according to the HL7 UDAP security IG, and the functional registration pathway would support applications that are unable to support dynamic registration. And then furthermore, to support dynamic registration, we propose that certified API developers with API technology certified to the G30 criterion would need to publish trust community information that's necessary for dynamic registration as part of the API maintenance of certification requirements. So now going to authentication and authorization requirements. We propose for this criterion to require authentication and authorization for patient access. To enable patients to authorize access for registered apps, we propose the Health IT module must support authentication and authorization according to the Smart App Launch IG during the process of granting access to patient data. And then furthermore, to enable authentication of dynamically registered applications, we propose the Health IT module must support asymmetric certificate-based authentication according to the HL7 UDAP security IG. And then I'll also note that we propose to require multi-factor authentication for patient-facing authentication. Okay, so now going into sort of the data response requirements. So first are the payer drug formulary API. So we propose that the Health IT module must publish information regarding the payer's drug formulary information according to the HL7 FHIR Da Vinci Payer Data Exchange, or PDEX, US Drug Formulary Implementation Guide. And this implementation specification can enable consumers, members, and patients to understand the costs and alternatives for drugs that have been prescribed and to compare their drug costs across different insurance plans. To support the exchange of formulary data that is integrated with protected health information, or PHI, or personally identifiable information, PII, we propose that the Health IT module must provide support for an authenticated API according to the PDEX US Drug Formulary IG, and then to support the exchange of formulary data that is publicly available and which does not contain PHI or PII, we propose the Health IT module must provide support for an unauthenticated API according to the PDEX US Drug Formulary IG. Going into some other of the data response requirements, we propose to require support for access to patient health coverage and claims information. We propose that the Health IT module must allow patients to access and share clinical and coverage information via a standardized API according to the Da Vinci PDEX IG. And this implementation specification enables a payer to create a member's health history using clinical resources based on US core profiles. We propose that the Health IT module must support the requirements included in the PDEX server capability statement and the relevant HL7 FHIR profiles, resources, and operations included in the IG. We further propose that the Health IT module must support the capabilities in the US core server capability statement for each of the data classes and data elements included in the US CDI standard. And we'll note that most of the US CDI and US core requirements are met through the PDEX server capability statement requirement. Okay, so that's the G30 criterion summary proposal. We can go to the next slide for a summary of the G31 and G32 criteria proposals. So for some background, we propose to adopt the G31 provider access API client criterion and the G32 provider access API server criterion. And these proposed certification criteria would enable a healthcare provider to access information on a patient's claims. The proposed certification criteria could further enable access by a healthcare provider to clinical information maintained by the payer from sources other than claims as well, such as laboratory results, clinical data from CCDA documents, information from admit, discharge, and transfer messages, information from immunization registries, and information related to medication from pharmacy networks. And such information can provide a more complete clinical profile for the provider, as well as allow the provider to make appropriate treatment decisions based on the clinical information and the patient's individual coverage information. And additionally, this proposal would align with CMS requirements for payers to establish a provider access API finalized in the CMS interoperability and prior authorization funnel. And these proposed criteria would reference many specifications as well, including the Karen Blue Button IG, DaVinci PDEX IG, and US Core IG. And we propose to include the G31 Provider Access API client criterion in the base EHR definition. Next slide, please. Okay, so now providing an overview of the technical requirements of the proposed G31 and G32 criteria. So starting with G31, the proposed G31 criterion requires support for capabilities to enable a provider to request and receive patient clinical and coverage information from a payer and receive and process the response. So this includes support for the ability to request patient history according to the PDEX IG, and the proposed G31 criterion also requires support for the ability to receive, parse, and write patient health history and coverage information to the Health IT module. The G31 criterion proposal includes requirements to support the ability to interact with a PDEX server as a client. And this includes support for all of the corresponding client capabilities for requirements described in the PDEX server capability statement and the relevant HL7 FHIR profiles, resources, and operations included in the PDEX IG. Also, we'll propose support for all the corresponding client capabilities for requirements included in the C4BB capability statement from the Karen Blue Button IG, according to the Karen for Blue Button IG. And then furthermore, we propose support for the corresponding client capabilities described in the US Core server capability statement, according to the US Core IG, of course, for each of the data classes and data elements included in the US CDI standard. And then to support the transfer of information on groups of patients, we propose for the G31 criterion that the Health IT module must support the ability to request and receive information as a client according to the bulk data access implementation guide. Okay, so that was the G31 criterion proposal, the client proposal. Now talking about the G32 server proposal. So for the G32 Provider Access API server criterion, we propose to require support for the ability for a client to request patient health history, coverage, and claims information according to the PDEX IG. We also propose for the G32 criterion requirements from specifications such as Karen IG for Blue Button, US Core IG, and the US CDI standard. And we also propose for the G32 criterion, the Health IT module support the ability to identify patient clinical coverage and claim information based on the information provided by the client. And we further propose to require support for returning patient clinical coverage and non-financial claims and encounter information according to the PDEX IG. And then to support the transfer of information on groups of patients, we propose for the G32 criterion that the Health IT module must support responding to requests for patient data according to the FHIR R4 and bulk data access implementation guide. Next slide, please. Okay, and then now discussing the security requirements for the G32 proposed criterion. We propose to require 2 registration pathways, functional registration and dynamic registration. And reiterating again that the dynamic registration pathway would support applications that can support automated scalable registration according to the HL7 UDEP security IG. And the functional registration pathway would support applications unable to support dynamic registration. And for authentication and authorization, there are 2 categories of requirements to discuss, user and system. So for user-facing app requirements, we propose for the G32 criterion support for the ability to authenticate and authorize an app according to the process, during the process of granting access to patient data to users according to the PDEX IG and Smart App Launch IG. And we additionally propose to require support for asymmetric certificate-based authentication according to the HL7 UDAP Security IG for user-facing dynamically registered apps. And then for system app requirements, we propose to require support for the ability to authenticate and authorize an app during the process of granting access to patient data to system apps according to FHIR R4 and the bulk data access IG. And we propose to require support for system authentication authorization according to the requirements in the Smart App Launch IG for functionally registered system apps. And we also propose to require support for asymmetric certificate-based system authentication and authorization according to the HL7 UDAP Security IG for dynamically registered system apps. Next slide, and I'll pass it over to my colleague, Johnny.
Great, thanks, Scott. Fantastic. I'm going to describe the remaining G30 APIs that we have proposed in the HTI-2 proposed rule, starting with the pair-to-pair API at 172.15 G33. We propose to adopt this certification criterion, which specifies requirements for health IT that can be used by pairs to support the electronic exchange between pair systems, so pair-to-pair. And just like the criteria that Scott has been going over so far, this proposed criterion references the same standards, the Karen IG for Blue Button, DaVinci PDEX IG, and the US Core implementation guide. And some of the benefits are that the exchange of patient information between pairs can allow health information to follow a patient when they switch insurance plans and enable improved coordination of care, increased patient empowerment, and reduced administrative burden. And we'll also note that this aligns with the CMS requirements for payers to establish pair-to-pair access API, originally finalized in the CMS interoperability and patient access final rule and updated in the interoperability and prior authorization final rule, and references the recommended standards from those rules. We can go to the next slide. And so I'll go into a sort of more technical walkthrough like Scott did. You'll notice that these criteria have similar structures, and that was intentional to help folks navigate all of the proposed criteria. We have registration, authentication, authorization, and then information access. For the pair-to-pair API, inside of registration, we proposed requiring functional registration and dynamic registration according to the UDAP security implementation guide. And this will enable support for several registration pathways for other pairs to exchange information with each other. And then for authentication and authorization, system access, we propose requiring smart backend services, system authentication and authorization according to Smart App Launch to support the functional registration pathway, and then asymmetric certificate-based system authentication and authorization according to the UDAP implementation guide to support the dynamic registration pathway. And so that's the security stuff. And for information access, like I said, we're referencing a lot of the same implementation guides, including in the PDEX FHIR IG, we are proposing required support for the operations of querying all of the clinical resources individually, $ patient everything, which is a like an export operation, and then bulk FHIR asynchronous protocols as referenced in the PDEX FHIR IG. And then as far as those are the operations, and as far as the content that is required, we propose to require clinical and content information by supporting the resources in the PDEX server capability statement, and then claims information by supporting the resources in the Karen IG for Blue Button C4BB capability statement, and then US CDI and US Core IG profiles according to the US Core server capability statement. And you can see we've tried to illustrate diagrams here to show sort of a high-level information flow between pairs and pairs. So the pair will be serving as both the API and the client for this exchange. So we can go to the next slide. Great. And now I will cover the prior authorization API proposed criteria for providers and payers for 173.15, G34, and G35, respectively. So for the overview, we propose to adopt these criteria as part of the certification program for prior authorization for providers and payers at G34 and 35. And these proposed requirements include specifications for providers to request coverage requirements and assemble and submit documentation for prior authorization. And the for providers, well, the payer criterion supports the payer's ability to provide the information about coverage and documentation requirements, and then receive prior authorization requests from providers. These criteria are different than the ones that we've covered thus far, in that they are referencing other standards that have actually been developed by the Da Vinci group, including the Da Vinci Coverage Requirements Discovery Implementation Guide, Document Templates and Rules, and the Prior Authorization Support Implementation Guides, which describe a framework for prior authorization exchange. And walking through some of the benefits, these criteria have the potential to reduce administrative burden associated with prior authorization processes, which are largely manual today. And by streamlining this electronic prior authorization process, patients can hopefully receive more rapid information about whether treatments are approved. These criteria align with the CMS requirements for payers to establish prior authorization APIs, and with the requirements for participants in the Promoting Interoperability programs to report on new prior authorization measures, which were both finalized in the CMS Interoperability and Prior Authorization Final Rule. And they also reference the same recommended standards and are aligned with those in the CMS rules. We can go to the next slide. Fantastic. And so for this slide, I'm gonna go over some of the technical details for prior authorization API for provider at G34, and then the next slide we'll do the payer at G35. And these criteria are organized sort of in a way that aligns with the prior authorization framework that's developed by Da Vinci. So you can see the sections are coverage discovery, documentation and rules exchange, and then prior authorization submission and receive response. And so in coverage discovery, since this is the provider that is initiating the prior authorization request, we have, according to the CRD Fire IG, the coverage requirements discovery Fire IG, support appointment book, encounter start, encounter discharge, order dispatch, order select, and order sign CDS hooks. So these will enable the initiation of prior authorization requests once those hooks have been activated. And then as part of the documentation and rules exchange Fire IG, we have two components to this. One is the full DTR EHR, which we require providers in the proposed criterion proposed requires the providers support the full DTR EHR capability statement. And I recommend going to the implementation guide and reading the requirements there. and also the light DTR EHR capabilities include functional registration, dynamic registration, smart user auth, and then UDAP B2B user auth. And in a nutshell, the light DTR EHR sort of offloads some of the documentation and rules exchange capabilities onto an app that is working with the EHR. And the full DTR EHR sort of does all of those capabilities internally. And so recommend reading the preamble and the associated standards for all the detailed information on that. And then the last piece is prior authorization submission and receive response. This is the provider. We propose requiring that the provider support the ability to submit or the health IT module support the ability to submit a prior authorization request to a payer system, including the requirements in the EHR PAS capabilities section of the PAS implementation guide, and then support the ability to consume and process a claim response. And there are more detailed requirements in the criterion, which I recommend referring to the rule to read. We can go to the next slide. Fantastic. So the next one we'll discuss is the prior authorization API payer criterion, the proposed criterion at 173.15 G35. This one is organized in a similar way to the provider criterion at G34, in that it's organized according to coverage discovery, documentation, and rules exchange, and then prior authorization, receipt, and response. And I'll just dive into each. So for coverage discovery, we propose requiring that the payer health IT module support the identification of coverage requirements by receiving and responding to decision support requests as a service according to the CRD Fire IG, which is the coverage requirements discovery Fire IG, and then support for the CRD server capability statement, which is found in the CRD Fire IG, and it describes all of the capabilities that are expected to be supported by the systems claiming that role. And then the next piece after coverage discovery, so this is once the decision support request has been sent over, we propose requiring support for documentation and rules exchange, including functional registration, dynamic registration, smart backend services, and UDAP system auth. And this will enable whether it's the EHR natively or an app that is assisting the EHR with the requirements in G34, will enable that client to register with the payer system to enable the exchange of documentation and rules that can facilitate the necessary documentation for prior authorization. And we also propose to require that they support the ability to receive and respond to prior authorization documentation requests with documentation templates and rules, and then also support the DTR payer service capability statement, which is found in the documentation templates and rules Fire implementation guide. And then finally, the prior authorization receipt and response section of this criterion, we propose requiring that payers support functional registration, dynamic registration, smart backend services, and UDAP system auth to enable the client to interact with the system in order to actually send over the prior authorization documentation and then provide back a response, and propose requiring the Health IT module to support the ability to receive, process, and respond to a prior authorization request. There's a lot here in these criterion. I definitely recommend reading some of the technical background in these three implementation guides that form the prior authorization framework, and the preamble and the HTI-2 proposed rule and the regulatory text as well. We can go to the next slide. Great, and then the final sort of GPP API criterion is G36. This is the Provider Directory API, health plan coverage. And we propose to adopt this criterion in G36, 17315 G36, which specifies the technical requirements for Health IT that can be used by payers to publish information regarding the providers that participate in their networks. And this proposed criterion references standards, including the PDEX PlanNet implementation guide. And the benefit for this criterion is that it allows patients to understand which providers, facilities, and pharmacies are covered by their current or future plan, and can improve patients' ability to find the right provider and healthcare plan. And it can also help providers understand the same. And we can go to the next slide. Fantastic. So just obviously this one's a little simpler than the others. The Provider Directory API health plan coverage technical details include proposed support for the ability to publish the following according to the PDEX PlanNet, the payers' insurance plans, associated networks, and organization and providers that participate in these networks, and then also support the PlanNet capability statement according to the PDEX PlanNet implementation guide. And that just describes all of the capabilities that the payer will need to support in order to fully support the implementation guide. And you can sort of see here's the diagram where the payer is publishing an API of provider directory information and is being accessed by a client. This could be a patient that's using an app to see the provider directory, or a provider that's using an app to see this information. We can go to the next slide. Fantastic. So in addition to the criteria that we proposed for payers and patients and providers, we also proposed some accompanying condition and maintenance and certification requirements. And these are described in general here. Again, like the other slides, I recommend going to the proposed rule to read the details of these sections, both in the regulation text and in the accompanying preamble. And to start, in 17404, we expanded the application programming interfaces. We proposed expanding the application programming interfaces applicability to G30 through 36. Beyond what is now currently G7 through G10. And if we look at B1, this is the maintenance and certification requirement. This is authenticity verification and registration for production use. So we aligned this with the existing G10 requirements for authenticity verification and registration by for production use, by including any of the criteria that include a registration step in here. So you can see G30, G32, G33, 34, and 35. And then for B2, publication of API discovery details for patient access, we also aligned this with the B10 criterion, which this currently applies to. And for the developers that are certified to G30, they have to meet similar requirements to G10 to publish API discovery details that can be used by patients to access their health information, including B2I, which is API discovery terms, B2II, which is API discovery and user access brand format. That's the smart user access brands. And then IV, which is trust community discovery for dynamic registration, which will support the ability for dynamically registered apps to register with these servers that are certified to G30. And then for 174.4b3, publication of, we've also proposed publication of API discovery details for payer information. This is an entirely new maintenance of certification requirement, and this applies to G32, G33, 35, and 36. And we proposed requiring that certified API developers that are certified to these criteria must publicly publish API discovery details for all of its customers, and then publish these according to the user access brands and endpoint section of the Smart App Launch Framework Implementation Guide. And then the API discovery details published according to the section must be reviewed quarterly and, as necessary, updated by the certified API developer. Fantastic. So I think we can go to the next slide. Great. And I'm going to hand it back over to Alex Baker to close this out.
Great. Thank you so much, Johnny. And thanks to you and Scott for unpacking these important and very detailed proposals in the HTI-2 proposed rule. We'll just note that there is some additional guidance being put in the chat just about our ability to respond to comments through this webinar, but there is a link there to the official way to submit your official comments on the rule, which are due by October 4th. And has been said many times on these webinars, but I will just repeat that we very much would like your comments on these proposals. It is extremely important to us to be able to have the public's feedback through official channels so that we can better understand how folks are responding to the proposals. So we are very grateful for that, and we look forward to seeing the comments that folks are going to submit by October 4th. And with that, I think that will close out this presentation. Thanks again to everyone for joining and learning about these proposed criteria. We really appreciate the time and attention to what we believe are some pretty important new proposals for the ONC Health IT certification program. And with that, I think we'll close for the day. Thank you.